Okay guys, today we're going to learn about the endocrine and metabolic system. It's chapter 8 in your book. It is not an e-chapter. So I hope you have looked at it. It is quite packed full. You're going to need to read the chapter. So here are your objectives. Nothing ever likes to start. Here we go. Maybe not. Here's the objectives, okay? We're going to look at your endocrine system. It's composed of various glands that are capable of synthesis and release of special chemical messengers, which are known as hormones. They're transported by the bloodstream to the cells and organs on which they have a specific regulatory effect. The hypothalamus is the main integrative center for the endocrine and autonomic nervous system. It controls the function of endocrine organs by neural and hormonal pathways. The endocrine system and nervous system control and integrate body function to maintain homeostasis. When you look at this picture came from the bottom of page 205. It is basically your endocrine glands. You have your hypothalamus, which we discussed is your control center, remember? And you have your pituitary gland, which you have an anterior lobe and a posterior lobe. You have your thyroid. You have your adrenal glands, your pancreas, and your islets of Langerhans, which is in there. You have your ovaries and your testes. All right. Oh, I went the wrong way. Sorry. Okay, I'm still going the wrong way. All right, from a pathology from an endocrine system. Dysfunctions are classified as either as hypo or hyperfunction. The causes may be inflammation or a tumor in the hypothalamus, the pituitary gland, or other endocrine glands. You can have chronic endocrine abnormalities. They are a common health problem requiring lifelong hormone replacement for survival. This is just in general in regards to endocrine pathologies. The endocrine versus the nervous system. Your endocrine sends messages in the form of hormones through the blood. The hormonal effects have slower onset but maintain longer duration of action. The nervous system sends messages along nerve fibers, eliciting a very swift neural response. These two systems, the endocrine and the nervous system, meet at the hypothalamic pituitary interface. Remember, the hypothalamus integrates the endocrine and the autonomic nervous system and controls the function of endocrine organs by neural and hormonal pathways. I'm going to repeat that for you. The hypothalamus integrates the endocrine and autonomic nervous system and controls the function of the endocrine organs by neural and hormonal pathways. There are 5 general functions of the endocrine system. Right there they are. The differentiation of reproductive and central nervous system of the developing fetus. Stimulation of sequential growth and development during childhood and adolescence, coordination of male and female reproductive systems, the maintenance of optimal internal environment throughout the lifespan to keep homeostasis happening, and the initiation of corrective and adaptive responses when emergency demands occur. Here's another picture, just looking at the endocrine itself with the various endocrine glands. You have hypothalamic control. Hypothalamus has direct control over the anterior and posterior portions of the pituitary gland via neural pathways. The neural stimulation to the posterior pituitary provokes secretion of 2 effector hormones, an antidiuretic hormone, which is ADH, and oxytocin. And it also exerts hormonal control at the anterior pituitary through releasing and inhibiting factors. The hypothalamic hormones work in 2 ways. They release tropic, which are stimulating hormones, such as adrenocorticotropic hormone, ACTH, thyroid stimulating hormone, or follicle stimulating hormones, which is FSH. The other way it works is the effector hormones are released or inhibited. Examples of effector hormones are growth hormone and prolactin, and the effects of the adrenal cortex, thyroid, and gonads. Hormonal effects in response to the hypothalamus, the posterior pituitary secretes oxytocin and ADH, and remember ADH is called an antidiuretic hormone. Oxytocin stimulates the contraction of the uterus and is responsible for milk letdown reflex in lactating females. And the antidiuretic hormone controls the concentration of body fluids by altering the permeability of kidney and to conserve the water. It does this by the plasma volume and osmolality as monitored by the hypothalamic neurons. The anterior pituitary secretes prolactin, which stimulates milk production, and human growth hormone. Human growth hormone stimulates growth by increasing protein synthesis and fat mobilization and decreasing carbohydrate utilization. Hyposecretion of human growth hormone results in dwarfism. Hypersecretion of human growth hormone results in gigantism in children and acromegaly in adults. And there is a picture of that in your book in regards to on page 211, figure 8.3 is a picture of acromegaly in an adult. And it's the overgrowth of bone in the face and the head, and you can see that in that picture. And picture B is a picture of overgrowth of the hands. Your thyroid gland is the thyroid hormones are necessary for normal development, growth and development. They act on many tissues to regulate our basal metabolism and increase metabolic activity and protein synthesis. The thyroid gland secretes thyroxine, which is T4, which is more abundant in the bloodstream than T3. That is more. Sorry, I forgot that. And triiodithyronine, T3 basically, is more active in directing the production of proteins vital to cell function. Hyposecretion causes varying degrees of hypothyroidism. Hypersecretion causes hyperthyroidism. Excessive secretion of thyroid-stimulating hormone from the pituitary causes thyroid gland hyperplasia, which is a goiter. You have parathyroid glands that secrete parathyroid hormone. It regulates calcium and phosphate metabolism. Hyperparathyroidism causes hypercalcemia. Hypoparathyroidism causes hypocalcemia. Pathologic changes in calcium affecting the bone bring these conditions to the therapist's attention. So you could see bone effect. If I have hypocalcemia, then I could have an increased risk for osteopenia, osteoporosis, right? Your pancreas produces glucagon from the alpha cells and insulin from the beta cells. Glucagon releases stored glucose to raise the blood glucose levels. Insulin facilitates glucose transport, glucose storage. It stimulates protein synthesis and enhances fatty acid uptake and storage. Insulin deficiency causes diabetes mellitus. Insulin excess can be exogenous or as a result of a tumor of beta cells, which is called insulinoma. Excess insulin equals hypoglycemia. Adrenal cortex secretes mineralocorticoids, glucocorticoids, and sex steroids. Okay, so I flipped back to this slide because you have an excess of insulin, which is hypoglycemia, but that also hypoglycemia means you have low blood sugar. And that just kind of threw me when I said that to you guys. So anyhow, I just wanted to clarify that. And I'm going backwards again, sorry. The adrenal cortex secretes mineralocorticoids, glucocorticoids, and sex steroids. Aldosterone, which is a mineralocorticoid, regulates the reabsorption of sodium and the excretion of potassium by the kidneys. It also is involved in regulation of blood pressure. And excess can result in two ways. You can have primary and secondary. If it's primary, you develop hyperplasia or adrenal adenoma, and secondary can be due to CHF or cirrhosis. The adrenal medulla is an aggregate of nervous tissue that produces the catecholamines involved in fight or flight response, which is epinephrine or norepinephrine. A neuroendocrine response to stress. The endocrine system, together with the immune system and the nervous system, mount the integrated response to stressors. So when we become stressed, a neuroendocrine response occurs, and that occurs due to the endocrine system, together with the immune system and the nervous system. The neuroendocrine response to stress, the sympathetic nervous system is aroused during the stress response. This causes the medulla of the adrenal gland to release catecholamines into the bloodstream. Simultaneously, the pituitary gland releases a variety of hormones, including ADH, which is an antidiuretic hormone, prolactin, your growth hormone, and the adrenocorticotropic hormone from the anterior pituitary gland. Catecholamines are organic compounds that play an important role in stress response. They are released at sympathetic nerve endings. It increases the rate and force of muscular contraction of the heart, which therefore increases cardiac output. It constricts peripheral blood vessels, which increases blood pressure. It elevates blood glucose levels by hepatic and skeletal glycogenolysis. And it promotes increase in blood lipids by increasing catabolism. Cortisol is the principal glucocorticoid hormone released by the adrenal cortex. It regulates the metabolism of proteins, carbohydrates, and lipids to cause elevation in blood glucose level. It results in increased blood glucose and plasma lipid levels and promotes formation of ketone bodies when insulin secretion is insufficient. It's essential to norepinephrine-induced vasoconstriction. It dampens the body's inflammatory response to invasion by foreign agents. It also helps to preserve the integrity of body cells at the site of the inflammatory response and also inhibits fibroblast proliferation and function. You have other hormones, endorphins and growth hormones. Endorphins are a group of opiate-like peptides produced naturally. They modulate the transmission of pain perception by raising the pain threshold and producing sedation and euphoria. Remember the gating mechanism theory? Actually, that's not that. Sorry, that is not that. Your endorphins are used in regards to TENS. Remember, when we have chronic pain, we want to use TENS to affect the endorphins. You have growth hormone. It stimulates and controls the rate of skeletal and visceral growth by directly influencing protein, carbohydrates, and lipid metabolism. You have prolactin. It stimulates growth of breast tissue and sustains milk production in postpartum mammals. You have testosterone, which regulates secondary male characteristics and sex drive. When you look at this, this is a nice little synopsis of the endocrine system in review. It's the organs of the endocrine system and other organs containing tissues that secrete hormones, which are TAN. You have your hypothalamus here. You have your pituitary gland, your thyroid gland, your adrenal glands, your pancreas, your pineal gland, which we really have not talked about, your parathyroid glands, and organs with secondary endocrine functions. Those are listed there as well. This is a nice little summary chart for you guys. How does aging affect the endocrine system? Are changes in the endocrine system function a cause of aging or a natural consequence of aging? Or is it just simply failure to maintain homeostasis? The conventional view that normal aging changes predispose to aging-related disease and contribute to poor recovery of aging adults from illness. During episodes of ill health, the thyroid's ability to maintain homeostasis is often limited. Subtle changes occur in the pituitary, adrenal, and thyroid function. Changes in glucose homeostasis, reproductive function, and calcium metabolism are more apparent as an individual ages. Aging is associated with higher incidence of disorders of the endocrine system, including type 2 diabetes, hypothyroidism, and increased incidence of atypical endocrine diseases. Cellular damage associated with aging may contribute to endocrine gland dysfunction or alterations in responsiveness of target organs. There's this theory called the neuroendocrine theory of aging. It attempts to explain the altered biologic activity of hormones, its altering circulating levels of hormones, altered secretory response of endocrine glands, an altered metabolism of hormones, and a loss of circadian control of hormone release. The theory suggests that cells are programmed to function only for a given time, and then they don't function anymore, or they don't function as well. So what about menopause? Age, because that is also involved in regards to the endocrine system, remember? It's an important biological role in women in control of reproductive and non-reproductive function, and regulates mood, memory, cognition, behavior, the immune function, locomotor systems, and cardiovascular functions. The pituitary gland with aging undergoes both anatomic and histological changes, and by 80 years old, the weight of the anterior pituitary lobe is reduced by 75%, along with reduced blood supply and higher incidence of adenomas and cysts. Carol just walked in.
Hi.
You're going to hear doors opening and closing. She's going to...
Exciting. Pituitary gland.
Oh, yes. Lord help us. She's going to be filing some stuff, so you're going to hear some stuff opening and closing in the background. It'll be all right. All right, so we move to thyroid gland. As we age, the thyroid gland becomes relatively smaller and fibrotic, and its position becomes lower lying and retrosternal. Its blood supply is reduced, and secretions of the thyroid hormones may diminish. The parathyroid gland demonstrates tissue changes with advanced age, but no major change in the apparent levels of parathyroid hormone. Hyperparathyroidism occurs primarily in adults greater than 50 years old, and most commonly results from a single adenoma. Your adrenal glands with aging develop more fibrous tissue, but as a result of a compensatory feedback mechanism, there's no relative alteration apparent in functional cortisol levels, which is beneficial. Musculoskeletal signs and symptoms of endocrine disease may vary depending on the gland affected and whether pathology results in hyperfunction and hypofunction. And you guys need to look at page 209, table 8.2. It gives you different signs and symptoms of endocrine dysfunction for the neuromusculoskeletal system and systemically what you might see. Okay? You need to be aware that patients with an underlying but undiagnosed endocrine disorder may initially present with a musculoskeletal problem, and that clients with established endocrine disorders are not cured by hormonal replacement or suppression. So we may initially think in therapy that we're treating someone for a musculoskeletal issue, but really what's going on is there's some type of underlying undiagnosed endocrine problem. So you always want to think about that and go back to the adage, are we making someone better? And if we don't see a change in our treatment to where things are better, then we have to begin to figure out, is it the treatment or is there something else going on that maybe hasn't been discovered in regards to this patient? And if you have a patient who comes in with a known endocrine disorder that they take medications for, know that that is only going to suppress or hold symptoms at bay. It's not going to cure the endocrine disorder. Take, for example, someone who takes bioidentical hormones or takes just hormones as they begin to enter perimenopause or menopause. It doesn't cure someone going through menopause. It just helps suppress some of the symptoms that go along with it. So if you can think about that, that might help you. All right, so now we're going to talk about specific endocrine disorders in regards to the glands that are affected and what you might see. When we talk about the pituitary gland, it's a small oval gland located at the base of the skull in an indentation of the sphenoid bone directly posterior to the sphenoid sinus. So it sits right in here, okay? The pituitary gland is known as the master gland because of its role in regulating other endocrine glands. It's joined by the hypothalamus, by the pituitary stalk, and is influenced by the hypothalamus through releasing and inhibiting factors. There's two parts to the pituitary gland. You have an anterior part and an anterior lobe and a posterior lobe. The anterior pituitary versus the posterior pituitary. The anterior produces 6 different hormones. There they are. The posterior part is a downward offshoot of the hypothalamus and contains many nerve fibers. ADH, which is an antidiuretic hormone, which is a vasopressin, and oxytocin are produced in the hypothalamus and then stored and released by the posterior pituitary. The anterior pituitary lobe disorders occur most frequently in the anterior lobe. They're most often caused by tumors, pituitary infarction, genetic disorders, or trauma. Hyperpituitarism, and that is spelled wrong. Hypopituitarism, I guess I didn't spell it wrong. No, they're both right. Hypopituitarism and local compression of brain tissue by expanding tumor masses. You can develop those symptoms, hyperpituitarism or hypopituitarism by compression of brain tissue by expanding tumor masses. Hyperpituitarism is oversecretion of one or more of their hormones secreted by the pituitary gland. More specifically, the growth hormone resulting in acromegaly or gigantism is caused primarily by a hormone-secreting pituitary tumor. Typically, it's a benign adenoma. Other syndromes that may include Cushing's disease, amenorrhea, or hyperthyroidism. If someone has hyperpituitarism from an orthopedic standpoint, you have to think about the skeletal manifestations that develop can resemble arthritis of the hands, osteoarthritis of the spine. You can have osteophyte formation and widening of joint space as a result of increased cartilage thickening. In the late stages of hyperpituitarism, joint spaces become narrowed and chondrocalcinosis may be present. Gigantism is the overgrowth of long bones, and acromegaly is increased bone thickness and hypertrophy of soft tissues. Both result of growth hormone secreting adenomas of the anterior pituitary gland. They're characterized by connective tissue overgrowth resulting in coarsened facial features, protrusion of the jaw, thickened nose and tongue, broad hands with spade-like fingers. Your book has a picture of these, okay? Gigantism develops in children before the age when epiphysis of bones close, develops abruptly, and the child may grow to be 9 feet tall. As tumors enlarge and invade the normal tissue and target organ, functions are impaired by the loss of hormones. And acromegaly is a disease of adults and develops after the closure of epiphysis. It develops slowly. The bones are most affected are the face, the jaw, hands, and feet. It occurs equally in men and women, usually between the ages of 30 and 50, and you may experience local manifestations, including headache, blindness, and lethargy. And here's a picture of a gentleman who has gigantism. Look at him compared to the other people in the room. He's extremely tall. Here's a progression of acromegaly. Okay. Hypopituitarism is also known as panhypopituitarism or dwarfism, results from decreased or absent hormonal secretion by the pituitary gland. It's a generalized condition caused by partial or total failure of all 6 anterior pituitary's vital hormones. You have growth hormone deficiency, which causes one to have short stature and delayed growth and delayed puberty. You have secondary adrenocortical insufficiency, which is diminished synthesis of ACTH by the pituitary gland, which in turn results in diminished secretion of adrenocortical hormones. From a sexual reproductive standpoint, there may be deficiencies in gonadotropins with someone who has hypopituitarism. All right, posterior lobe. So all of that previously was anterior pituitary lobe disorders. Now we're going to talk about posterior lobe disorders. You have diabetes insipidus, which is a physiologic imbalance of water secondary to antidiuretic hormone deficiency, which results from an injury or loss of function of the hypothalamus. The neurohypophyseal tract or posterior pituitary can result in diabetes insipidus. Treatment is with a vasopressin or synthetic derivative. When ADH production decreases, the kidney tubules fail to reabsorb water. The end result is excretion of large amounts of dilute urine. And you might also see someone might complain of excessive thirst, excessive urination at night, dehydration, fatigue, and irritability if they have diabetes insipidus. You can also have something called syndrome of inappropriate antidiuretic hormone. I have never seen anyone with this. Or if I have, I don't know it. Okay, just put that in your hat because it's probably not going to show up on a test. Associated with excessive release of antidiuretic hormone, which disturbs fluid and electrolyte imbalance, resulting in water imbalance. There's a wide variety of causes, but more specifically, pituitary damage resulting from infection or trauma. Tumors can cause unregulated production of antidiuretic hormone, leading to severe hyponatremia as well. Remember, hyponatremia is sodium depletion. It results in lethargy, nausea, anorexia, and generalized weakness. Mild hyponatremia, you have increased thirst, muscle cramps, and lethargy. Rapid onset of hyponatremia can result in coma, convulsions, or death. So the syndrome of inappropriate antidiuretic hormone is the opposite of diabetes insipidus. Treatment of a diabetes insipidus with vasopressin can lead to syndrome of inappropriate antidiuretic hormone if excessive amounts are administered. Water intoxication occurs as a result of fluid retention instead of large fluid losses. Let's talk about your thyroid gland. It's located in the anterior portion of the lower neck, below the larynx on both sides of and anterior to the trachea. The primary hormones are thyroxine, which is T4, and triiodithyronine, which is T3, and calcitronin. T3 and T4 regulate the metabolic rate of the body and increase protein synthesis. Calcitonin has a weak physiologic effect on calcium and phosphorus balance in the body. Thyroid function is regulated by the hypothalamus and pituitary feedback controls. So how does the thyroid function? When the hypothalamus senses that circulating levels have dropped, it signals the pituitary gland, which sends thyroid stimulating hormone to the thyroid to trigger the release of thyroid hormones. Susceptibility to thyroid disease is largely determined by your genetic makeup, age, and sex. Thyroid hormone acts on nearly all body tissues, so excessive deficient secretion affects various body systems. If someone has a thyroid dysfunction, you may observe changes in nails, skin, eyes, hair, the GI tract, the respiratory tract, heart and blood vessels, nervous tissue, bone, and muscle. Hypothyroidism is an excessive release of thyroid hormone, thyrotoxicosis. This term used to describe the clinical manifestations that occur when the body tissues are stimulated by increased thyroid hormone. When you have an increase in thyroid hormone, and it's deemed hypothyroidism, it creates a generalized elevation of your body's metabolism. The most common form of hypothyroidism is the overfunction of the gland as a whole. It increases T4 production and accounts for 85% of hyperparathyroidism. It's an autoimmune disease. And here's a picture. The image on the right is an example of a goiter that develops. And the picture on the left is something called exophthalmosis, where the eyes bulge out. And it's associated with hypersecretion of the thyroid gland. So these are symptoms you might see someone who has Graves' disease. They might look like this. This is the pathophysiology of Graves' disease. You can kind of look at that and go along. All right. None of it's covered up by the counter in the bottom. Okay. Systemic manifestations of hypothyroidism can be found in table 214. I can't even talk. Page 214, table 8.3 at the very bottom of it. They have different systemic manifestations in regards to the central nervous system, what you might see from a cardiovascular and pulmonary system, musculoskeletal, integumentary, what you could see ocular-wise with the exophthalmos, and genitourinary effects. Okay. Neuromuscular manifestations of hypothyroidism is periarthritis, proximal muscle weakness accompanied by muscle atrophy. It's mostly seen in the thigh muscles and pelvic girdle. It may first notice problems with coordination, balance, or weakness in the legs. And how might this present with the patient functionally? Well, they're going to have weakness and coordination and balance problems, right? And we are probably going to see the beginning for that, but do they get better? But if they're not getting better, why? Is it the treatment that we're doing? It's because they have an underlying endocrine issue. If they have an underlying endocrine issue, you might want to think hypothyroidism. Hypothyroidism refers to a deficiency of thyroid hormone in the adult that results in generalized slowed body metabolism. It's the most common disorder of thyroid function in the US and Canada. It's categorized as type 1 and type 2. Type 1 is primary, type 2 is secondary. The preponderance of cases are type 1. It occurs as a result of reduced functional thyroid tissue mass and impaired hormonal synthesis and release. Type 2, which is secondary, occurs as a result of inadequate stimulation of the gland because of pituitary or hypothalamic disease. That's really a small percentage of why someone might have hypothyroidism. It's 4 times more prevalent in women than men. It's congenital. The highest incidence is between 30 to 60 years old, and 95% of all cases are primary. Primary hypothyroidism is the loss of thyroid tissue, leads to decreased secretion of the thyroid hormone. This leads to increased thyroid stimulating hormone secretion from the anterior pituitary to attempt to stimulate additional thyroid hormone. And it's not an adequate response to TSH. There's not enough T3 and T4 to reach the body's organs, and the body function begins to slow. The pituitary continues to release thyroid stimulating hormone, TSH, resulting in elevated TSH levels in the body, in the blood. Hypothyroidism secondary is most commonly the result of failure of the pituitary to synthesize and release adequate amounts of TSH. To look at hypothyroidism clinical manifestations, look at page 216 and the table 8.4, and it goes through this different systemic manifestations. Here is a schematic of kind of an easier way to look at that from a systemic standpoint of what are signs and symptoms of hypothyroidism in an individual. Parathyroid glands. There are 2 parathyroid glands are located on the posterior surface of each lobe of the thyroid gland. They secrete parathyroid hormone, which regulates calcium and phosphorus metabolism. Carol's leaving you. She's had all she can have of it.
Too much fun for one day.
Parathyroid hormone exerts its effects by increasing the release of calcium and phosphate from the bones. So it causes bone demineralization, increasing the absorption of calcium and excretion of phosphate by the kidneys, and promoting calcium in the GI tract. There's a great review box on page 220 that has a comparison of hypo and hyperparathyroidism. There are different characteristics. Box 8.3, take a perusal of that. You have adrenal glands left, right? You have your kidneys, which are here, and here's your adrenal glands. They're located on the upper part of each kidney and consist of 2 distinct parts, an outer cortex and an inner medulla. Together, they are major factors in the body's response to stress. The outer cortex is responsible for the secretion of mineral corticoids, which is steroid hormones, right? It's responsible for producing glucocorticoids, which is the metabolism of glucose, and androgens, which are sex hormones. The medulla aspect of the adrenal glands is derived from neural tissue and secretes epinephrine and norepinephrine. Primary adrenal insufficiency is also known as Addison's disease. It's the result of a disorder within the adrenal gland and affects 4 in 100,000 adults. You have insufficient cortisol release. It's considered to be an autoimmune disease. It results in decreased production of cortisol and aldosterone. Patients may exhibit weakness, they're exhausted, hypotensive, diminished response to stress, weight loss, nausea, and vomiting. And here's a picture of someone with Addison's disease. Okay. Secondary adrenal insufficiency is caused by other conditions outside of the adrenals, such as the hypothalamic or pituitary tumors, removal of the pituitary, or other causes. It's related to cortisol deficiencies only. The gland is still intact, so aldosterone is secreted normally, but lack of stimulation from ACTH, which is the adrenocorticotropic hormones, results in deficient cortisol secretion. As a result, hyperpigmentation is not a part of the clinical presentation. Cushing's syndrome is hypercortisolism. It's excess of cortisol in the body. Can result as hyperfunction of adrenal gland and excess of corticosteroid medication or excess of ACTH stimulation. Cushing's syndrome is a results from the adrenal gland oversecretion or from increased doses of corticosteroid medication. So some of your COPD patients who have been on a corticosteroid for quite some time have the ability to develop Cushing's syndrome. Cushing's, excuse me, Cushing's disease, when hypercortisolism results from oversecretion of acetylcholine ACTH from the pituitary. And here's a picture of it. So you can have a very rounded face. They have a thoracic hump. They bruise easily. They have abdominal weight gain and stretch marks. And therapists are more likely to treat people who have developed medication-induced Cushing's syndrome. It occurs mainly in women with age onset between 20 and 40 years old. Medication-induced Cushing's syndrome occurs when receiving large doses of cortisol, hydrocortisone, or cortisol derivatives administered for a number of inflammatory disorders, such as asthma or rheumatoid arthritis. You just want to be aware of that. What I would encourage you to do is you try to go through this chapter 8, is you write out the different glands and separate where they are and what they do. And how they might present. In class, I'm going to lecture on diabetes on Thursday, okay?